Hi friends, so in this video we'll be discussing one of the very important electrolyte disturbances, which is hyperkalemia. So what is hyperkalemia? It is defined with the serum potassium levels being greater than 5.5 milliequivalents per liter, right? Then what are your causes of hyperkalemia? Now it could be because of increased intake. Now this increased intake can be in form of your IV fluids containing potassium, or it will be because of high potassium containing foods, or it could be because of your potassium containing drugs. Right. Next important cause of your hyperkalemia could be because of increased tissue breakdown. So now what could be the causes of this increased tissue breakdown? It could be because of hemolysis, or it could be because of rhabdomyolysis, and it could be because of a generalized catabolic state of the body. Right now, apart from this, it could be because of the shift of potassium outside the cell. So what are the changes that are going to cause your potassium out of the cell? Now it could be because of your tissue damage, right? So if there is a tissue damage, the potassiums would shift out of the cell into the blood, causing hyperkalemia. It could be because of metabolic acidosis, right? Then it could be because of uncontrolled diabetes, and then it could be because of your aldosterone deficiency, right? Then there could be increased potassium also because of impaired excretion. That means that the potassium is not being able to be excreted outside the body. So what could be the causes of it? Yes, one of the first and most important cause would be in case of your renal failure. Then if we use a potassium sparing diuretic, right, then it could be because of Addison's disease, which would be causing your impaired renal tubular excretion, right? And it could be also because of an effective circulatory volume depletion, which would in turn be leading to hyperkalemia, right? So we have been discussing in a lot regarding the drugs. So let's make a list of few drugs that can cause your hyperkalemia. So it would be your ACE inhibitors, which are commonly used hypertensives, right? Then it could be because of heparin and cyclosporin. The list is endless, but let's remember these three important drugs which can cause your hyperkalemia, right? And then there could be some state of a pseudo hyperkalemia, which occurs usually in a traumatic, right? Traumatic hemolysis, usually when we draw blood, right? So it would be a common experience when you will be going for your internship that you have a traumatic hemolysis, that while drawing your blood, and when the report comes you would find a high potassium content, but then that is basically a pseudo hyperkalemia, which is caused due to the defective technique of you drawing the blood, right? And another important cause of a pseudo hyperkalemia would be your thrombocytosis, right? So these are the few of the causes of hyperkalemia. So if you remember it in this way, using like increased intake, tissue breakdown, shift of potassium out of cell, and impaired excretion, and drugs, and pseudo hyperkalemia, it would be quite easy for you guys to remember it, right? Now regarding the clinical features, so let's again read the clinical features the systematic wise. So what would happen if it in the general? So in general there would be vague muscular weakness, right? Now in your gastrointestinal system, what could it cause? It could cause nausea, could cause vomiting, right? Then in your neuromuscular purpose, it could again cause a generalized weakness, right? Then it could cause a paralysis, and it could also lead to a respiratory failure, right? Then in your cardiovascular system, which is usually severely affected in case of hyperkalemia, it could cause your arrest and your arrhythmias, right? So these are few of your important symptoms or clinical features of your hyperkalemia. Now, next important thing which I would want you all to remember regarding hyperkalemia would be your ECG changes. So what are your ECG changes? So usually when it is between 6 to 7 milliequivalent per liter, you usually find tall, peaked T waves, right? Now, when it further increases, you can see loss of P waves and widening of QRS, right? On further increase, what it can actually do is it can cause AV dissociation, right? And it can cause ventricular tachycardia or a ventricular fibrillation, which is a serious threat to life, right? So these are few of your important ECG changes which I would want you all to remember. Now regarding the management, since it is so much detrimental on your heart, the management can be divided into two groups. It could be your emergency treatment and it could be your non-emergency treatment. So first let's discuss the emergency treatment. So emergency treatment can be further subclassified into three broad categories. The first one would be your antagonism of membrane effects. So how would you achieve that? This can be achieved with the help of IV calcium it could be achieved with the help of IV calcium gluconate, right? Now your next would be the movement of potassium into the cells, right? The cause was potassium movement out of the cell. So how would your potassium movement be into the cell, right? So what would be your causes, what would be your drugs that would cause your potassium movement into the cells, right? It would include your insulin and glucose, right? Then it would include use of your injection sodium bicarbonate, right? And use of beta 2 agonist, right? That is salbutamol, right? So these three drugs would cause your potassium movement into the cells, right? And then your last category would include your removal of potassium from the body, which would include use of diuretics, right? Then it would include your use of resins, and it would include hemodialysis, right? And your non-emergency treatment would include dietary potassium restriction, avoiding medications which is causing hyperkalemia, use of loop and thiazide diuretics, cation exchange resins, and the specific etiological treatment like for Addison's disease or aldosterone deficiency, which are the causative agents of your hyperkalemia, right? And we would end this discussion by giving you the doses of the few drugs that we have discussed, like the calcium gluconate. It would be 10% solution of 10 ml ampoule, which is usually 10 to 20 ml infused over 5 to 10 minutes. Then insulin glucose, which is 25 to 50 gram glucose together with 10 to 20 units of insulin, right? Followed by 5% dextrose, 100 ml per hour to prevent late hypoglycemia. The dose of your sodium bicarbonate would be 7.5% 50 to 100 ml as IV bolus over 10 to 20 minutes, followed by IV sodium bicarbonate drip, and your beta adrenergic agonist, which would be your nasal inhalation, that is usually 20 mg in 4 ml of saline, right? So those who would want to remember the doses, these are your doses for you remember for the drugs used in hyperkalemia. In case even if you do not remember your doses, at least remember the name of your drugs, right? So this is all about your hyperkalemia. right? Thank you.